Alberto Morales and Mike Gibson talking to you about coronary CT and coronary CT angiography. There's a lot of words out there, Alberto. Even I get confused. And I've had these studies. So walk us through some of the differences. You hear about, well, know your calcium score. What's the difference between that and a coronary CT? So let's start there. What is a coronary calcium score?
Yeah, so a coronary calcium score is basically a non-contrasted CT scan of the chest. And so basically you're not injecting dye, you're basically taking CAT scan images of the chest, and what you're looking for is basically calcium deposits in the coronary vessels. And these calcium deposits are basically, if you think of an atherosclerotic plaque, it goes through various stages. It's always starts out as lipid filled, necrotic, and then it starts to fibrose, and then microcalcification sets in, and then it ultimately starts to calcify. And then there's a certain density that can be picked up by Agatson's units, which is what we measure when we're measuring the calcium score, Agatson score. And it's basically the density of the calcium deposits in the arteries. And we can measure that number, and we can locate where these calcium deposits are. It's a good measure of someone developing atherosclerosis, but it doesn't tell you who all have disease. The problem is obviously these plaques start out at various stages, and so it can take someone who's already developed coronary artery disease, these soft plaques, up to 8 to 10 years before they start to calcify. And so if you get a calcium score of 0, you might be believe or have the impression that you are free of disease. We've scanned over 10,000 patients in my office here at South Tampa Cardiology, and what we have found is roughly 35 to 45% of people. I'm still putting the numbers together, but roughly 4 out of every 10 patients with a 0 calcium score actually have soft plaques. And the
Wow.
problem with that, and the reason why that's important, is we know that the majority of heart attacks occur in these soft plaques. So these are the plaques that we worry about, not the calcified plaques. These calcified plaques tend to be more stable. Problem is, obviously, if you have calcium, you probably have a cousin next to it that's fibrous and fibrofatty. That's very a plaque that would be considered risky plaque. And so that's the differences, and that's why a calcium score is very additive, but it doesn't answer all the questions.
So, we hear about hardening of the arteries. That's why we have hardening of the arteries because they get bony and calcified. But those aren't the ones that are going to get you. I like the word you use. It tells you that you may have a cousin down the street that's going to cause some problems. That's the non-calcified one. Now, it's interesting. You said it well. Having a calcium score does not tell you about the non-calcified fat in your arteries. And you can still have fatty arteries and have a calcium score of 0. Very important. So now tell us about what is a coronary CT angiogram? How is that different?
So that is usually additive to a calcium score, where you now are going to access a vein and you're going to inject contrast in the vein so that it's sort of like shining a light inside the arteries, right? So a calcium score, you don't get to see inside. You can only see calcium deposits. If you want to see inside the arteries and get a full breadth of what's really going on inside the coronaries, you need something to help open and shine a light inside, and that's why we use contrast material. And so with the contrast material, you're now able to look inside the arteries. You're able to assess the amount of plaque volume. You're able to assess the plaque characteristics of the disease. So for instance, now you can measure these types of plaques. You can measure the soft plaques. And in that soft plaque range, you have a spectrum. You have a spectrum of fibrous plaque, soft plaque, which is very inflammable, such as low attenuation plaque. So now we can measure the full spectrum of it. You can actually hover over these plaques, or you can use a product such as Clearly, where you can or any AI analysis tool where you can actually use the Hounsfield units to determine these plaque characteristics. And as we know, these plaque characteristics, such as low attenuation plaque and fibrofatty plaques, these are the plaques that tend to rupture and cause heart attacks. So it's very important to highlight those plaques and then have a full breath and discussion with the patient that these are the probably the risky plaques that we need to treat. And it's really irregardless whether or not they're stenotic or not. So I tend to look at plaques or coronary artery disease in sort of four pillars. One is, how much plaque volume do you have in your arteries? Do you have extensive plaque or do you have mild plaque? Because that tells you how long a patient's been having plaque burden in their arteries. It could be anywhere from stage one, clearly has a beautiful staging system that looks at percent atheroma and total plaque volume and can kind of tell you where how long you've had plaque, if you're in the low zone, the intermediate zone, or the advanced stage. And so this tells me a lot about how long this patient has been suffering from coronary artery disease, anywhere from 10 years to 30 or 40 years, depending on how much plaque volume. Obviously, the more plaque volume you have, the riskier, the more likely you are to have an event. So we know that if you have for instance, a total plaque volume of over 400 cubic millimeters of plaque, your risk goes up exponentially of having an event over the next 10 years. We also know that the type of plaque, so this is the other pillar, is the quality of the plaque. What type of plaque do you have? Do you have calcified plaque? Do you have non-calcified plaque? Do you have a mixture of both? Other characteristics we can look at are, that are very like, such as spotty calcification, napkin ring, all these and low attenuation plaque. We can now get the whole histology of really what's going on. So if you think about, you know, uh, clearly, or plaque AI analysis, where we can actually assess the plaque burden, is sort of like a histology. So the CT scan is sort of like, doing, or the doing a mammogram, for instance, right? You do a mammogram and you identify a pathology. That's like the CT scan. And then getting the biopsy and sending it to the pathology lab and getting the actual histology of it. That's what AI can do for you, where you can analyze these plaques and characterize patients according to that risk. The third pillar is obviously stenosis, right? And I think that, to me, stenosis is more of a how symptomatic is this patient? Is this patient suffering from blockages? And traditionally, we've thought of patients with high grade blockages at the highest of risk. But what we have found is obviously that over 75% of people that have heart attacks are in these non obstructive plaques, not the high advanced plaques. And so, what that tells me is that percent stenosis, severe stenosis, is probably not the marker that is causing these heart attacks. It probably determines that a patient has a lot of plaque volume in their arteries, and as a result, they have high grade stenosis. But there's something in the composition of the arteries that is leading to these plaques, and that's where the histology comes in. And then the fourth pillar obviously is perivascular inflammation, where we can assess the perivascular fat and assess whether or not a patient, is. So these are the four things that I look at when I'm looking at a coronary CTA, and you can get all this breadth of data that you can't get on a calcium score, you can't get on stress testing, which is going to be the game changer in the way of the future, as you start seeing a lot of people using it more and more.
So, I wanted to work out, got a calcium score. It was high. My LP Little A was high. And then my doctor said, well, we better get one of those CT scans. So it's a separate test, a second test. You do get some radiation with it. And then we looked at it, and you can just look at it visually. That's one way to do it. But then, as you said, you can have it quantitated. That's this new AI quantitation. And so then we measured how much plaque I had, the volume of the plaque, the type of plaque. And so, thank God, nothing was really all that
That's
narrow.
great.
But it was important to see the picture. When you see it's like, wow, it's like looking like never having seen your teeth or something before. You see it for the first time. You're like, wow, I got some stuff there I need to take care of. Now, the other thing to do is we looked at it and we said, well, are any of those like meaningful in terms of the blood flow? So then we did, this FFR measurement, this fractional flow reserve. Talk to us a little bit about that. And that's kind of like the stress test of the artery, right? I mean, you're looking to see, are those blockages really blocking blood flow, right?
Absolutely. So traditionally, we've always been really good with CT at identifying plaque, right? Identifying stenosis. So, if you had to put a stress test in a patient or a CT scan, the stress test is not going to be nearly as accurate at identifying high grade stenosis or at least plaque. So it's very sensitive CT. Where it comes in its problems is in its specificity. So not all two readers and not all technology can lead to us the ability to call a high grade lesion. There tends to be some overlay in patients where we may call a 70% lesion, and then when they go to the cath lab, it's probably only a 50% lesion, right? And so for these intermediate lesions where we tend to, we don't want to send these patients to the cath lab, what the Achilles heel was, we would always say, well, it'd be nice if we could test it further, but as a result, let's send them for a stress test or something. Well, in the cath lab, they have a tool and it's called invasive FFR. And what they do is a pressure wire that goes across the area of stenosis. And right there in real time, they're able to measure a drop off of flow. And so, you're taking a sensor proximal to the lesion and distal to the lesion. And if the lesion is not causing any significant change, then the pressure in this side and the pressure in this side should be equal. And what we've noticed is if the pressure drops below zero point 0.8 or 0.75, then that lesion is causing significant impairment to blood flow to that artery. And we've determined that obviously these patients do better with potentially revascularization strategies. So we've applied that same technology initially through HeartFlow, which use computational fluid hemodynamics, and now we have all these AI-based methods and computer smart learning that have replicated this exact same technology that we can do invasively, but now we can take your same CT that you had done to analyze all these different characteristics and identify someone with maybe a 70% stenosis, but you're not quite sure if it's causing problems. Now you could submit it for this FFR or this ischemia testing to determine whether or not that lesion is significant. This aims to reduce inappropriate sending of patients to the cath lab. So if you got someone with a 60% stenosis and the FFR is normal, then you can opt to treat this patient aggressive and medically. If you have a patient who's symptomatic and obviously has a significant lesion and a positive FFR, that's a patient you can easily, clear your mind, say this is the appropriate strategy. We're going to send him for invasive strategies. And so that's where, as opposed to doing multiple tests, now we can do it. It's a one-stop shop all with AI and with these algorithms and with just getting one CT scan.
Yeah, so I got the calcium thing first. That tells me, do I have a bunch of old hard arteries? Then I got the CT, and then my doctor and I looked at it and said, looks pretty good, but let's get the measurements of how much fat you have in your arteries. That was the third step. And then we said, yeah, you got a little fat in there, but is it blocking the blood flow? And that was the fourth step that we just talked about.
Yep.
Does does any of this change practice? I heard recently in an interview I did that, when you get the CT scan, it changes management in about half the patients. Is that
I would
true?
say that it's a game changer when you're able to show a patient their arteries and show them, obviously you want to show them what normal arteries look like and various stages of heart disease show. And we have posters in our wall that can illustrate that. And we take pictures of every single scan we do and we show patients. When you have the power of show and tell, a patient is going to look at that and the trust and obviously the confidence of what's going on, it empowers them to take action, right? As opposed to reading, well, your cholesterol's high. For instance, you had no idea you had coronary artery disease. You
My
followed the
cholesterol
injection.
wasn't that bad.
It
My
wasn't that
cholesterol
bad, but
was
you had a
70.
high Lp(a) and it wasn't being monitored, right? So
Right.
it's not standard protocol to monitor that. And then and so all these years you're told, hey, everything looks good, everything looks good, and then you finally take a picture of something and you see something, and now it's a call to action, right? So and so patients see it, they act upon it, and compliance goes up. And we saw that in Scott Hart trial where 5 years into the trial, they saw just the arm of CT being able to show patient their arteries, and the escalation in therapy, the initiation of therapy led to a 41% reduction in heart attack and death. And now, fast forward 10 years, Scott Hart, that still holds true. So, stress testing in one arm, CT in the other arm, the CT arm has led to a 41% reduction in heart attack and death over the stress arm. So, we already know that CT leads to improved compliance with therapy and improved outcomes. And so that's kind of what's pushed into this first line of therapy as far as initiation and managing and evaluating patients with chest pain, but also in evaluating patients at risk.
Yeah, my bad cholesterol wasn't that bad. It was 70. I was taking a couple medicines, a torvastatin, a statin, and and ezetimibe, and I thought I was doing good, and then that calcium score came back high. But then when we saw the fat in my arteries, that made us look, well, maybe I need to get that other thing measured, that Lp(a). Nothing we could really do about it directly, but it didn't cause me to then get on a PCSK9 inhibitor,
Perfect.
drive my LDL down to 27. So, you know, you're right. It does change. A picture's worth 1,000 words. It's worth 1,000 extra days of treatment or something. I mean, it really changes behavior seeing that picture.
Absolutely.
Well, this has been great. Where do you see things going? Any new changes we can look forward to?
In CT, yeah, I see, I have obviously clearly has a transform trial, which is looking at screening asymptomatic patients. Scott Hart 2 is looking at screening asymptomatic patients. I've been screening asymptomatic patients now for about 2.5 years. I have a registry called the Tampa Insight Registry, and we have over 10,000 patients. So there's going to be a
Wow.
lot of data out there now, probably over the next year or two, looking at screening, treating, and re-imaging in a surveillance pattern, and what meds lead to improve outcomes. And I think that there's going to be significant changes in the guidelines over the next couple of years.
You're putting a guy like me out of business. I mean, I'm a cardiac cath guy, and you're just doing all this without having to get in there and put holes in the arteries and vein
Yeah, I
the
mean
veins.
we're seeing a lot of regression with disease. And so for taking a guy like me who's a preventative cardiologist who has an advanced imaging background, now you're able to take a picture of somebody for the first time, see what's going on. I also run surveys on all my patients, and roughly, I just looked at just 1,000 patients just that we've scanned, and that all had CAD. 96% of them said, just asking them, do you have CAD? Do you have heart disease? They all said they didn't, right? So there's a misconception of what's going on underneath with what is possibly really going on. So with that, you're able to show patients, hey, you have coronary artery disease, you have atherosclerosis. This is what we're going to do. We're going to put you on these aggressive pillars of therapy, and then we're not going to just hope and pray. We're actually going to follow up with a serial imaging and show regression. And right now we've got about 70 something cases of plaque regression. We're taking patients with 85% blockages, bringing them down to 60%, 70 down to 40%, and it's pretty regular now, to the point where I'm waiting to publish all this data pretty soon, and it's going to be exciting. It's going to be exciting.
In 1987, there were 27 films in the corner of a room at the Brigham and Women's Hospital. They told me as a young kid, go measure those blockages. We're going to make them go away with cholesterol-lowering medicines. And it was called the Harvard Atherosclerosis Reversibility Project. And we didn't really make a bunch of a dent. Of course, we didn't have very good drugs back then. And we were just looking at the inside the donut. We were only looking at the lumen of the artery. We weren't looking at the walls.
Yeah.
So it's been so exciting over the past 30 years to see all the advances over 35 years in how we are diagnosing this, how we've moved from just looking at the inside of the plumbing like a plumber to looking at the wall. My pathology professor in medical school was Seymour Glagoff. And
Oh,
of
yeah,
course,
Gladkopf study.
yeah,
Yeah,
that's he showed us that, yeah, your arteries, they don't get narrowed, but they expand with all the fat for a while, and then once they get 40% full, they start to grow inward.
yeah.
To now seeing
Positive
how
and
we're
inward
able,
muscle.
yeah, now how we're able to really measure blood flow too. Of course, I had invented a lot of the measures we use in the cath lab, but it's great to see
It's
them
awesome.
now, used quantitatively to measure all this. Well, Berta, thank you so much for joining us today. I think you helped clear up a lot of things about what's a calcium score, what's a CT, what's a quantitative one, what's quantitative FFR. Very simple, easy to understand conversation. Thanks for joining us, and I'd love to see what you're going to say, what you're going to publish. Thanks.
I appreciate it, Dr. Gibson. Thank you so much for having me.